Really excited on their sugar high to hear about PHIPA and public health. Basically, what Khaled and I are going to go through today is I'm going to do the first part of the presentation, then Khaled will take over and he'll speak about a case study. It's called the asset study. He's going to speak to some techniques for de-identification that were very important and relevant to how the study subsequently progressed and how the de-identification work informed the issues that arose, the data sharing agreement, and then we're going to wrap up. Please feel free to ask questions. If you could wait to the end, maybe that would be great, and I'll be glad to repeat them. It sort of occurred to me that when they were seeking proposals for speaking today, that, you know, at that time, I can't remember how many months ago it was, but certainly there were issues surrounding the coming epidemic of H1N1. And I think we were maybe in the first phase, and then they predicted like second phase in the fall. And I sort of thought, well, this is kind of interesting, and it certainly will be timely, given the date of the conference, to speak to some public health issues, surveillance issues, and disclosure of data for public health purposes, and examine whether or not we've learned the lessons of SARS. For those of you who are on the front lines, and I'm sure there were many of you, either in the front lines in your healthcare sector organizations or trying to manage the privacy data sharing issues that arose during SARS, I think it's probably fair to say that there was a perception around that the law inhibited data sharing. And we certainly heard after the fact that one of the reasons that there wasn't enough control, monitoring, predicting with respect to managing the epidemic because of constraints on data sharing, and the perception that it was actually the law, that it was PHIPA, that prohibited the sharing. And part of the challenge at that time was that the Health Protection and Promotion Act did not list SARS. You know, there's a schedule to the HPPA that lists the communicable and reportable diseases. And part of the challenge back then was that SARS wasn't included in those lists. And there's a lot of disclosure provisions that make it permissible to share information about certain diseases, but people were concerned that it didn't specifically appear, so they couldn't share information. And subsequently, SARS was added to the HPP list, but it still wasn't clear to a lot of healthcare professionals how much information could be shared, when it could be shared, and to whom it could be shared. So again, this is some history, but I think it's kind of important to take us where we are today with respect to H1N1. You're probably aware there was a commission of inquiry chaired by Mr. Justice Campbell, and he wrote a report, and there were certain recommendations in that report. Recommendations vis-a-vis amendments to both PHIPA and the Health Protection and Promotion Act, and to allow for disclosures for the purposes of the HPPA. And essentially, this was to facilitate information sharing for public health purposes and the purposes of the HPPA, which are the prevention of the spread of disease and promotion of health. So one of the provisions that was added was the ability of health information custodians to disclose personal health information to the Chief Medical Officer of Health or medical officers of health, even in the absence of a statutory duty to report under the HPPA. And what I'm going to look at now is give you an overview of the framework of disclosures of personal health information for public health purposes in Ontario. And those of you familiar with disclosures, whether it's under PHIPA or other privacy legislation, know that there's two basic types: discretionary, where you've got a choice, and mandatory, which means, just like the word sounds, that you must do so. With respect to discretionary disclosures, health information custodians may disclose PHI without consent. And again, in this context, we're talking about disclosures without consent, but that are authorized by the legislation. So, as I said, those disclosures may be made to a chief medical officer of health within the HPPA for those public health purposes. And those are the purposes that are set out in the legislation that establishes the HPPA. Again, you may be aware that there's a new Ontario Agency for Health Protection and Promotion. Again, disclosures are permitted to that agency. Or, and this is interesting, those disclosures, so for example, if you are a hospital in Ontario, those disclosures of personal health information without consent for public health purposes may be made to a public health authority that's similar to the Ontario agency that's established under the laws of Canada. So we're talking about a federal agency, an agency in another Canadian province or territory, or in another jurisdiction. So that means an agency, let's take for example the CDC in Atlanta, that's where those disclosures are for purposes that are substantially similar to HPPA. So, you know, whether it's surveillance, public health protection, promotion, those disclosures are allowed. In those cases, the custodians, so if you're a hospital, you may do that data sharing without agreement. Okay, you don't need to sign anything. The data may just be disclosed. As I'm reiterating, it's a discretionary disclosure, and so custodians may choose to do so or not. With respect to disclosures for public health purposes, and there's always been some confusion I found about this, there's also mandatory disclosures. And those are set out in the HPPA. And in that act, identified healthcare practitioners, professionals, nurses, physicians, etc., and certain other groups, so school principals, hospitals, must disclose. Okay, this is a mandatory reporting of personal health information without consent in those certain examples in the Health Protection and Promotion Act. And you'll see influenza, so H1N1, the flu, is listed already and has been for years and years in the HPPA as a reportable and a communicable disease. So therefore, a physician, for example, that forms the opinion that a person has or may have the disease or may be infected with an agent must report to the medical officer of health. Similarly, hospital administrators have the same mandatory obligations if somebody who's made that notation in the chart comes to that opinion. And these are reports with identifiable patient information, as are the discretionary disclosures as well, because both of these are disclosures of personal health information for public health purposes, okay, whether they be on the discretionary side or what we call mandatory reporting. And of course, there's a link between the mandatory reporting under the public health, the HPPA legislation, and PHIPA, because PHIPA allows disclosures of personal health information without consent if permitted or required by law. So the linkage is looking to another piece of legislation, in this case the HPPA, for your requirement by law satisfaction to authorize your PHIPA disclosure. So the HPPA says you must disclose, PHIPA says you're allowed to disclose if permitted or required by other legislation, so the two fit together to satisfy the disclosure requirements. So that's the background with respect to mandatory discretionary disclosures under PHIPA. And now I'm going to turn this over to Khaled to to describe a project dealing with public health issues and some of the privacy concerns and data sharing matters that we had discussed.
Okay, well, thank you very much, Anita. So the project that Anita was referring to is called the ASSET project. It's the PI is Rick Davies at the Ottawa Heart Institute, and the objective of ASSET was to set up a syndromic surveillance system that's collecting data from the emergency departments of the 4 hospitals in Ottawa in real time and send that data to Ottawa Public Health. Real time means basically every 6 hours there's a data feed from each of the hospitals that's then analyzed, and specific syndromes are submitted to OPH with alerts where necessary. And it's the intention was that this would be an early indicator of disease outbreaks. Specific diseases are being targeted, like influenza or influenza-like illness and GI syndromes. And part of it included analyzing the free text and the chief complaints that come out of emergency to determine whether this indicates ILI or GI or not in order to generate alerts. And this is up and running now. I think the 4th hospital, the Montfort, is going live very soon or has already gone live. And the other 3 hospitals have been submitting data to OPH. Actually, OPH has better information about what's going on at the hospitals than most other, probably the organizations themselves, because they're getting real-time feeds of pre-analyzed data. So the story will tell you is how we got to this point, what we've learned, and how we think this kind of syndromic surveillance system can be facilitated in the future with other public health units and other hospitals in Ontario, and the data sharing agreements and other items that we're putting together as a package for other organizations that want to do this. So the kind of information that was requested initially was some kind of hospital identifier, the date and time of presentation of each patient, the chief complaint text, the patient's postal code, the patient's date of birth, the gender, and some case numbers so that patients can be tracked. And if there's a need to re-identify a patient for tracing purposes, then Ottawa Public Health would provide the case number to the hospital, who would then give the public health units more information about the patient so they can be contacted if needed. And one of the, of course, no patient identifiers were passed, so no name. It's not full date of birth, it was the age that was passed, no complete address, no OHIP number. And of course, obtaining patient consent for submitting this data was not practical for a number of reasons. Obvious one is resources. Getting consent from every patient who comes to emerge is not realistic. At CHEO, we normally get 120, 150 patients per day at emerge. First couple of weeks of November, it was about 350. It's just, there's no way we'd be getting consent from people coming in, especially if there's an outbreak. Just practically, it's not feasible. So we're really talking about providing information for public health purposes without consent. In terms of the uses and disclosures, well, of course, OPH was going to use the information for monitoring the situation and general situational awareness of what's going on. They may also do research on the data at now or at some point later on. So their own epidemiologists would do additional analysis on this information to understand causes or trends. And they may also provide the data to universities who are interested in doing research with this kind of data. So there are a couple of uses or purposes that were contemplated for this kind of information. And as part of this project, we ended up, set up a data sharing committee, which includes the privacy officers of the Ottawa hospitals. We ended up, even though it's not required, as Anita mentioned, because these were, even though the data contained influenza patients, all data on all patients was submitted. So in that case, it wasn't specific to any particular disease or condition or syndrome. Therefore, it falls under the discretionary disclosure piece. And part of the requirement or the wishes of the hospital was to have a data sharing agreement with Ottawa Public Health, even though it was not a requirement. And I think that was important because the legislation allows public health units to do quite a lot of things with this kind of data. It's very permissive. And the hospitals wanted to put some constraints on that. They wanted to define some parameters for how the data was used and subsequently disclosed. Okay, it's not me doing this. Right. So we'll talk, Anita will cover in more detail the elements of this data sharing agreement because we learned quite a lot from the process of putting in that data sharing agreement, the issues that come up that need to be addressed up front even though it's not a requirement. And also we put some conditions on the protection of the data and security requirements on the public health unit as part of this agreement. Okay, so one of the first issues that came up when we started the project had to do with identifiability. The hospitals did not want or were reluctant to share identifiable patient information or disclose identifiable patient information with the public health unit. Even though they're permitted, they can if they want to, they were reluctant to do so. So identifiability became an issue, and we looked at how do we de-identify emergency department data. And I'll just digress for a few seconds to draw a parallel with another project we're working on, and this has to do with family physicians. So I'm involved in another project with family physicians, and one of the issues that is known is that family doctors are also reluctant to provide data to public health units, and we wanted to find out why. So we did a series of focus groups at the annual convention of family doctors at the end of October to understand why they were often reluctant to provide data for public health purposes. And one of the main issues that came up was we really want to make sure that the data we provide about our patients is de-identified or is anonymized. So identifiability is a key requirement for providing data to public health. That was the case when we did the focus groups with the family doctors, and it was the case with the Ottawa hospitals when they were going to provide data to Ottawa Public Health. So now I'll talk about identifiability. So this graph shows you some results of a study we did with our colleagues at McGill, David Buckridge and Robin Tamlin. And the x-axis is the number of characters in the postal code, and the y-axis is uniqueness, is percentage of people who are unique. And the objective was to find out what makes Canadians unique based on just very simple demographic information. So we got data on 25% of the residents of the island of Montreal over an 11-year period from the RAMQ, which is the Quebec provincial insurer. And we used that to estimate uniqueness over time. So as you can see, with just the postal code, the percentage of uniques is very small, right? So just the postal code doesn't make Montrealers unique. However, when you add the full date of birth with the postal code, almost 97% of the population is unique. So essentially the postal code and the date of birth are a unique identifier. Now we're comfortable generalizing this to other urban areas in Canada. There are issues with generalizing it to rural areas. But it's important to understand that just with very simple demographics, individuals become unique very quickly. And of course, including only the first three characters of the postal code, 79% of the population is unique. And if you, of course, have longitudinal data, so if you have data on individuals over time, then let's say over a 3-year period, it just goes up, right? So uniqueness is much higher for longitudinal data. And by longitudinal, I mean we have their address or their postal code over a number of years. So say if it's a 3-year period, then we have their address at the beginning of year 1, the beginning of year 2, and beginning of year 3. If you generalize the date of birth, say, to year of birth, of course the uniqueness goes down, but still the full postal code and year of birth makes about 65% of the population unique. So this is important because when custodians are releasing information with basic demographics, and given their emphasis on making it de-identified or anonymous, we have to understand how to ensure this anonymity, and including postal code information and date of birth information, which are two key variables in the requested data from the emergency departments, becomes problematic. So in principle, we have a problem. Now let's look at the actual analysis of the emergency department data. All right, well, I think we'll just keep going and hope for the best. So the approach we took to looking at this identifiability issue is we need to decide whether the data that's being released by the emergency department is identifiable or not. So we have to choose a threshold of, when does the data become identifiable, right? And the way we approach this is by looking at the overall risk. So when we give data to an external organization or any organization, we look at three things which are shown at the bottom here. We look at their practices. We call it the mitigating controls, which essentially are the security and privacy practices. We look at the sensitivity of the data and what consent was put in place when the data was collected, and then the motives and capacity of the data recipient. And based on that, we decide what the risk of identification is and how much the identification needs to be done to the data. So we will apply these concepts to the two potential data recipients for the asset project, the Ottawa Public Health and the researchers who were asking for the data from Ottawa Public Health. So we obtained data on over 2 years of emergency department data from CHEO, so it's a medium-sized children's hospital in Ottawa. It's 108,000 presentations, and we looked at the key variables that were requested, so the data presentation, the postal code, the date of birth, and the gender. And we did a risk assessment on that, and we were very permissive. So for giving data to Ottawa Public Health, we said, well, they would not be motivated to re-identify patients unless they had to. They had good practices in place to protect the data, and the invasion of privacy risk was relatively small. So the threshold we used was quite permissive. And as you can see here, the 100% of the records had a high risk of re-identification, right? So even with a permissive threshold, all of the records were considered risky if we were to provide, the exact date of presentation, the exact postal code, etc. And one of the reasons, of course, is that when you include these 4 pieces of information, almost all of the patients were unique, right? So if I know when a patient came, the date, if I know their date of birth, if I know their postal code and their gender, they are unique amongst all other patients who came to CHEO. Given the chart that I showed you before, all we really need is the date of birth and postal code to know that they are unique. But if you add their presentation date, it's clear that they will definitely be unique. So the original data that comes out of the system is highly identifiable. So we tried to de-identify the data, and we went back and forth and had various negotiations, and what we ended up with was providing the public health unit with the first 3 characters of the postal code, the year of birth, the date of presentation. They need the date of presentation because they need to track patients over time. So they need to know the date. That's not negotiable. It's very hard for this data to be useful if you don't have the date of presentation, and the gender. But even when you do that, when you remove the postal code, you don't have you have the 3 characters of the postal code, you only have the year of birth. Still, 100% of the patients had a high risk of re-identification. At the end, we couldn't come up with a data set that could be reasonably de-identified, or that we could say the data was de-identified in order to provide them to the public health unit. So what I'm showing you now is what we actually gave. We gave data presentation, first 3 characters, year of birth, and gender. Even though the risk was high, the hospital had the discretion of providing the data, so they were allowed to do this, and the final decision was not to do more to the data, to anonymize it because it would become useless. So the data sharing agreement and all subsequent decisions were made on the understanding that this is identifiable information. Okay, with OPH that wasn't an issue. And we tried different things. We tried to increase the threshold quite a bit, try to make it very, very, very permissive and be able to justify it. There was just no way to identify this data and still have it retain any utility. Okay, so the second issue was the data set for the researchers. Now, as I mentioned before, we looked at 3 criteria. We looked at the security and privacy practices, we looked at their motives and capacity, and we looked at the invasion of privacy. The problem with the researchers, at least the ones that were known at the time, was that their security and privacy practices were uncertain. And there were signs that they were quite lousy, actually. And we were not able to have an audit done in order to verify whether the practices were great or not so great. So for that, we set a low threshold. We said, this is high risk. We cannot verify that this research group or organization has good practices to protect data, personal health information. Therefore, we will set a low threshold. And when we did that, of course, 100% of the records were identifiable. We tried very hard to de-identify the data. So we ran an automatic algorithm to de-identify the data, and what we could give them was the quarter and year of presentation, the first 2 characters of the postal code, the year of birth, and the gender. But quarter and year presentation is not very useful if you want to track an outbreak, right? And that was the only de-identification that was possible that we could give them, and it wasn't good enough for their purposes. So at the end of the day, we were not able to de-identify the data appropriately for the researchers either. As of today, they still haven't obtained data from the emergency department data, at least not from us. I think they may have obtained the data from some other hospitals. I can't speak to that, but certainly from us, they haven't obtained the data because we cannot give them useful data, and the useful data that we would give them would be identifiable, and we did not feel that it was good risk management to give them identifiable personal health information. So we'll put so even for researchers, it's identifiable health information, basically. So now Anita will talk about how the data sharing agreement was constructed to facilitate the disclosure to Ottawa Public Health, taking into account the fact that the data is identifiable. And just one last point, in the original data sharing agreement we did not cover everything Anita is going to cover. We did one, that's the one we were using. We learned a lot from that experience. So now we have put together a new data sharing agreement. We built a template around it that captures everything we've learned, and the objective there is to share this with other public health units and other hospitals so that they'd have a good template to start off with. So what Anita will describe is that template that we ended up constructing for reuse and dissemination of what we've learned from this project. Do it again for you.
Mm. Before I get into the details of the data sharing agreement, I just want to review the status and the classification of all the players in the asset project and all the data flows, and then I'll go into some of the issues that we had to manage in developing the template. So this particular slide is essentially a recap. It basically explains how PHIPA applies to the entities involved in sharing data. So the hospitals are HICS under PHIPA. As I mentioned before, they're permitted to disclose PHI to Ottawa Public Health for public health purposes. No patient consent is required, no agreement is required, but the hospitals did want that extra assurance, so we proceeded to deal with the agreement in a manner in which I'll deal with shortly. As Khaled mentioned, Ottawa Public Health also wanted to use the data for research. So again, in this situation, PHIPA doesn't require patient consent, but it does require a research agreement to be entered into between the hospitals and Ottawa Public Health. And then the third arm of what I always call the data chain was subsequent disclosures, again, as Khaled mentioned, that Ottawa Public Health contemplated to researchers in various universities. So this is, I always laid things out diagrammatically, so it's a little easier to explain to people and visualize myself instead of reading sections of the Act. But there are a couple of, excuse me, there are a couple of things that I just want to highlight here, and they were issues that subsequently came out in the agreement. And you'll see that, again, I highlight it's both disclosures for public health purposes and disclosures for research purposes. So with respect to one or the other, it would be pretty straightforward. But if you look at this paradigm and you see what's happening here, you know, there are some things that arose, and they were related to what particular REB would do the approvals for any of the research projects, how much the hospital had to be aware of or involved in subsequent data activities that were undertaken by Ottawa Public Health, for example, subsequent disclosure to researchers. There were issues with respect to how were they going to manage things like data breaches. How are they going to manage requests for access to the data, whether they be by individuals themselves or whether they be by, for example, the police or other entities when the disclosure was discretionary. So it's kind of interesting in that this situation raised a number of what I call the governance issues that Maureen was talking about just previously in the EHR context, in the sense that PHIPA didn't work all that well to cover off all the scenarios. And just as she said, sometimes legislation is never going to address all your issues, so you have to be kind of creative in an agreement with respect to how you limit everybody's risk, yet enable the data to be shared for the purposes in this particular scenario. So as I said, and this highlights the difference between the asset project and sort of reporting for H1N1, it's really the asset project is situational awareness. As Khaled said, they weren't tracking any particular condition, but rather it's syndromic surveillance, letting Ottawa Public Health have a real-time view of what conditions people were presenting with in the emerge room. As I mentioned, OPH wanted to do both, use it for those public health purposes and research. So what I was tasked with doing was developing a template that combined both of those things in one agreement. So it was a combined DSA, a data sharing agreement, with a research agreement. So first thing, and many of the issues as I go along were addressed because they were very good questions that were raised by people. Some people said, well, really, is the syndromic surveillance the way public health is going to use the data? Is that really a public health purpose? So can the hospitals disclose at all to assist in the project? And I think if you look at the HPPA and you look at the purposes of that legislation, I came to the conclusion that certainly the syndromic surveillance project met those parameters, and so therefore, excuse me, the disclosure was for public health purposes. So as we mentioned earlier, while it's not technically necessary, The hospitals wanted a comfort level given that Khaled had indicated that the data really was identifiable. So if you think about what we did here, Ottawa Public Health was kind of wearing two different hats. They were receiving information from the participating hospitals as a public health authority, okay, for public health purposes. So that's one hat, and those are custodians. But they were also receiving the data for research purposes. So they were a researcher. So they were wearing a different hat for those purposes. And those of you who are familiar with PHIPA, and I don't want to make this like a legal treatise or anything like that, but you'll know that there are different requirements, there are different authorizations, different abilities with respect to what entities can do with data when they've received it, using this as an example, for a public health purpose or for research purposes when they're a researcher. So it became a little bit complex with respect to sorting out OPHs wearing the two hats. So for example, this just deals with some of the examples that we had to consider in the data sharing agreement. Notification of individuals in the event of a data breach. And you'll recall that no on-its-face identifiers had been provided to OPH. The data was identifiable. But if you're going to develop a program and do an agreement based on the data being identifiable, then one would think that you're going to assume notification obligations in the event of a breach. The challenge here, though, was OPH, assume the breach would have happened there, they needed to get information from the hospital to be able to identify with certainty any and all individuals whose data may have been the subject of a breach. So while as a custodian, they might have primary responsibilities to notify, because all custodians have that responsibility, they couldn't do it without communicating with the hospital. So effectively, one could authenticate the individuals whose data was breached and who consequently would have to be notified. On the other hand, as we know, researchers are not allowed to do any direct notification. So wearing their research hat, OPH would have to have gone back to the hospital, and the hospital would either do the notification directly or contact the individuals to see if they would give their permission for OPH wearing their researcher hat to do the notification. So that's one example of how there's some complex issues. Some of the others, I've mentioned these briefly. Requests by individuals for access to their own PHI. Those again had to be referred back to the hospital for authentication and confirmatory issues, because OPH did not have all that data to be able to do that identification with certainty. OPH as a custodian being faced with discretionary disclosures. Okay, so say there's, law enforcement is not a good example. Nothing else comes to mind, but somebody else comes to OPH wearing their custodian hat and they want access to the data. And under PHIPA, OPH has the discretion. Well, what's the hospital going to think about that? So at this stage, the template has a provision whereby OPH consults with the hospital, but OPH has the final decision. And we had to write it that way because otherwise there's an argument that in law, OPH's discretion could have been fettered. That's what we call it, fettering your discretion. And that is basically receiving information from somebody else as to how to make your decision. So while they could consult with the hospital, at the end of the day, OPH had the final decision. And again, we had provisions with respect to OPH advising the hospital if they received a court order or subpoena or whatever. Because even if there is an obligation in a law enforcement context, for example, for OPH to disclose the data, you know, the hospital wanted to know what was happening with it, because eventually there could be a disclosure or a publicity somewhere down the road. Again, we had OPH communicate with the hospital if it received any privacy complaints from individuals, or an investigation or review by the privacy commissioner. And again, you know, in these communications between OPH and the hospital, it's got to be worked out what's practical. I mean, and what's interesting about this is that any of you that have managed a big outsourcing agreement, you always have contacts, like people that manage it on both sides that are the contacts. Well, here we're looking at a scenario where data could be 2 and 3 down the line. And so to have people responsible for managing and communicating these issues in a timely manner is very difficult on a practical basis. These are a couple of other things. From a research perspective, as we know, PHIPA needs a research agreement, so we had to write in that the parties would deem this to be the research agreement. And then, of course, there were all the other requirements with respect to REB approval and research plans and that kind of thing. Khaled mentioned the security safeguards. I think they sort of surprised a lot of people, but again, because the agreement and the project operated on the basis that the data was identifiable, those were the things that were required. And the template provides the hospital with the authority to request and public health to provide copies of any and all policies related to privacy, confidentiality, security, and there were provisions, there are provisions in the template for retention, destruction, return of the data. As Khaled said, it's being, the DSA, the template's being made available to all hospitals, public health units. At this stage, I'm sure it'll go through a number of iterations. I think there are some issues in there that it would be very helpful to get input not only from users, but also identified a couple privacy commissioners, but we wanted to get it out there and circulated. And you know, it will, as I said, go through a number of iterations. But it is, I think, a pretty good example of using a data sharing agreement to manage issues that aren't dealt with directly in the legislation. And I think that's, unfortunately, even though it's a bit unwieldy, the way things are going to have to be for the next little while if we don't have legislative support for some of them. While the agreement was being drafted and some of the parts of the project were going on, these are some of the questions that were raised. And the reason I put them here at the end is that they highlight why I started with the slides I did at the beginning. Because, excuse me, there was concerns that folks did and were asking a lot of questions about their rights and obligations to disclose for public health purposes, and what was the difference between what Khaled and the Asset Project was doing and mandatory disclosures and discretionary disclosures. And this is a really interesting, the last point is a very, very interesting one. And I'm not sure I'll explain it well enough so Khaled can jump in. But in effect, Asset uses a software program to take the data that appears in the emerge room charts and classify it, yes, and categorize it as a particular condition. Is that right?
I allow you or not
Okay, yes. Influenza, ILI is influenza-like symptoms or indicators or whatever, or not. Okay, so it's very interesting because a question arose, there's a software program doing this, not a healthcare professional. So, and I think it's a question that we may have to face in many cases in the future where professional opinions are actually executed by technology or software, the programs of which have been informed by professionals, but it's not an actual physical person doing this anymore. So just to wrap up, certainly the amendments to PHIPA and HPPA that were enacted here in Ontario as a result of lessons learned from SARS provide custodians with legal authority to disclose. And H1N1, quite frankly, is an easier case than SARS ever was because of the reasons I indicated up front, that influenza is a reportable and communicable disease and SARS isn't. As I mentioned, questions raised though during the asset agreement template development just gave me pause to reiterate and go through public health disclosures again. And I think, like in many issues we've talked about today, while technology certainly facilitates healthcare and development of programs, we see people always talk about the challenge of culture and educating custodians. So Ontario learned its lessons well from SARS, the legal framework's in place, but I think something that's very interesting when we talked earlier about managing risk proactively and reactively, I think the asset project is an example of proactive management of risk. It demonstrates practical, tested, accepted mechanism for data disclosures, monitoring the outbreaks on a continuous basis. And although Khaled didn't mention it, at one point they did do a retrospective study on Walkerton, right? And you all remember the outbreak, the GI outbreaks in Walkerton, to sort of test the validity of the assumption of the usefulness of this kind of surveillance tool as an early warning system. So they went back and looked at all the Walkerton data and everything that occurred during that period of time. And the hypothesis was proved in that it does provide a valid early warning system. Number one, of the outbreak of disease. Number two, of a lot of the geographic indicators, the sex of the people. So it allows public health planning at a very, very early stage, as opposed to planning almost in a vacuum, you know, without the basis of any substantive information. So the template supports this type of projects, and imagine if the project were implemented everywhere across Canada, we'd have this early warning system, and I hope nobody did this, but nobody would have to wait in line for 9 hours for a shot. Thank you. Any questions? Yes.